research for our research institute for MHRI. And I'm the director of the Women's Center for Positive Living, which is the regional referral center for prenatal care for women with HIV, as well as comprehensive preconception and gynecologic care. To give you a brief overview, I will be reviewing the HIV pandemic and current preventive strategies in cisgender women, and then I'll be sharing some PrEP research opportunities at MHRI, and I'll take your questions. Next slide. So I'll start with an overview of the HIV pandemic among cisgender women, as I mentioned, followed by current prevention strategies. And it's an especially exciting time to be speaking about this topic in light of World AIDS Day, but also in light of the associated recent change in the CDC guidelines around HIV prevention. Next slide. So to start with an international perspective, this heat map shows the proportional burden of HIV worldwide. In resource-rich settings, such as North America and Central and Western Europe, women comprise approximately 20 to 25% of new cases. However, in sub-Saharan Africa, which has the heaviest caseload of HIV, women, particularly young women, make up more than half of new cases. I saw a statistic recently that was like 57 to 68%, depending on the country. And women now comprise more than half of the 38 million individuals living with HIV worldwide, which translates to more than 19 million women living with HIV. The vast majority of women in both resource-rich and resource-limited settings acquire HIV through sexual transmission. And this growing prevalence of HIV among women worldwide is enabled by an estimated 8-fold higher sexual transmission efficacy from men to women, meaning that it's 8 times more likely for men to give HIV to women than in the reverse. But this inequity in HIV incidence is not due to biological differences between men and women. The HIV pandemic among women is driven by gender inequity and compounded by poverty. Since 2009, HIV/AIDS has been the leading cause of death among women of reproductive age around the world. And cisgender women bear the disproportionate burden of a preventable global pandemic. And HIV prevention in women remains critically underfunded and understudied relative to the pervasiveness and severity of the pandemic. Next slide. In the United States, the HIV epidemic is largely focused in the South and on the coasts. This slide depicts the prevalence of HIV among women in the US, and this heat map, although it's a couple years old, the distribution has actually changed very little. As you can see on the map on the left, parts of the South and New York City and Washington, DC have the highest rates of HIV. In terms of absolute numbers, you can see in the map on the right that there are also large pockets of women with HIV up and down the East and West coasts, as well as in the South. Next slide. Next, please. Over the past 2 decades, new HIV diagnoses, back one, are down overall among women in the US, down 25% among Black women, 20% among Latinas, and relatively stable among white women. This decrease is associated with an overall decrease in heterosexual transmission of HIV. And although this is really good news, racial disparities in HIV acquisition are still stark. 59% of new cases of HIV are among Black women and 16% among Latinas, compared to only 20% among white women. Next slide. Locally, as many of you are aware, Washington, DC is an epicenter of the HIV epidemic in the United States. Our prevalence changes from year to year and has gone down with gentrification, but hovers around 2%. And as you can see in this heat map, the majority of the cases are concentrated in wards 5, 6, 7, and 8. Next. And not surprisingly, women of color are disproportionately affected, representing 1 in 4 new cases of HIV in DC between 2015 to 2019. And the prevalence for women is over 8-fold higher than the national average. The DC Health reports that the prevalence among all women in DC is almost 1%, but is approximately double among women of reproductive age and even higher among women of color. Next. Nationally, Maryland ranks 5th in new adult HIV cases, below DC, Georgia, Louisiana, and Florida, and 9th highest in cumulative HIV cases, the majority of which are concentrated in the Baltimore City area. Women comprise almost 30% of new cases and a little over a third of all cases in the state of Maryland. Racial disparities are striking here as well. Black women represent 75% of new cases among women, bearing a disproportionate burden of the disease. Next slide. What makes these local statistics worse is that HIV is now highly preventable through both behavioral interventions, namely barrier contraception, such as condom use, and pre-exposure prophylaxis. Barrier contraception, specifically male condom use, is notably limited by issues of partner power discordance in addition to cost, stigma, and religious interdicts. Male condom use is implicitly dependent upon partner cooperation, highlighting the need for women-controlled HIV prevention options. The only FDA-approved pre-exposure prophylaxis drug, meaning a drug that you take before an exposure in order to prevent or decrease the risk of getting a disease. The only FDA-approved pre-exposure prophylaxis drug in cisgender women is a medication called tenofovir disoproxil fumarate emtricitabine, which I know is a mouthful. The non-generic name is Truvada, but I'll be referring to it as FTDF. So there's one other FDA-approved drug on the market for pre-exposure prophylaxis, however, not for women or not for cisgender women. Tenofovir alafenamide emtricitabine, or Descovy, which I'll refer to as FTAF compared to FTDF, is currently only approved in men who have sex with men and in transgender women who are having receptive anal intercourse. The Discover trial, which was a randomized controlled trial, and Dawn will talk about randomization later, for FTAF did not include cisgender women, and therefore cisgender women were not included in the FDA approval for the newest PrEP drug on the market. There are other drugs in the pipeline, such as the long-acting cabotegravir injection, the dapivirine vaginal ring, some forms of islatravir, among others, and we'll discuss some of these in upcoming slides. Unfortunately, women were largely excluded not only from this Discover trial, but also from much of the sentinel research on PrEP that was done on PrEP acceptability and PrEP feasibility. And the result of this exclusion is that we lack data on how we can empower and enable women to make preventative health choices. We don't understand the PrEP cascade for women, meaning that we don't understand what motivates women to initiate PrEP and continue PrEP. And as a result, we don't know how to effectively market PrEP, and PrEP is grossly underutilized by women, leaving them at increased risk for unnecessary HIV exposure. So despite the evidence that women have increased biological susceptibility, higher rates of new infection worldwide, and younger age at time of infection, women continue to be left out of some pivotal PrEP clinical trials. And this lack of inclusion in PrEP trials leads to less prevention option for women and a critical lack of data on appropriate PrEP dosing and efficacy in women. And this is especially relevant in pregnancy. Next slide. So HIV prevention in pregnancy is critically important because of the increased risk of maternal HIV acquisition during this period. This is a very busy slide, but the point of this slide is that multiple studies demonstrate that there's a between 2 and 10-fold increase in HIV acquisition during pregnancy and postpartum. This increased incidence is attributed to both behavioral and biological changes during pregnancy. So on the behavioral side, without the incentive to avoid pregnancy, condom use is decreased during pregnancy, leaving women at increased behavioral risk for exposure to HIV transmission. On the biological side, during pregnancy and postpartum, there's a variety of factors, including changes in immunity, increased genital tract inflammation, trauma to the genital tract during delivery. And all of this is especially important as if mom does acquire HIV in this incident pregnancy, there's a 10-fold increase of mother-to-child transmission compared to if mom had acquired HIV in a previous pregnancy or outside of pregnancy. Next slide. So the standard dose of PrEP is recommended in pregnancy, the same dose that someone would take outside of pregnancy, but PrEP dosing has not been prospectively studied in pregnancy. So there's never been a study that was designed to really effectively look at the dosing and what the appropriate dose was. There have been multiple retrospective studies, and several observational pharmacokinetic or PK studies that look at the appropriateness of dosing, although looking backwards, of pregnant women on FTDF for PrEP or FTDF for HIV treatment demonstrated significantly lower levels of tenofovir, one of the key two drugs in that medication, in the blood in the second and third trimester. And this decrease is associated with known pregnancy-associated changes. So specifically, there's an increase in the overall blood volume. So the PrEP is more dilute, and also increased excretion by the kidneys. So the PrEP drug is flushed out more quickly. And this is particularly concerning in the case of PrEP in that it may no longer be as protective. And the reason for concern in this case particularly is that we know that outside of pregnancy, near perfect adherence is required for non-pregnant women to achieve the same high efficacy, that greater than 90% efficacy that's been demonstrated in men who have sex with men. And this is due to differences in the way the PrEP drug concentrates and penetrates the cervical vaginal tissue versus the anus and the rectum. So if near perfect adherence is required outside of pregnancy, given all these known changes in pregnancy, there's concern that the standard dose may no longer be as protective. So we don't know that PrEP is less effective in pregnancy. And the reason we don't know is because it has never really been prospectively studied. But there aren't reports on that either yet. But the take-home message of this slide isn't that we shouldn't give PrEP to pregnant women or that we shouldn't do everything we can to prevent HIV in pregnancy. It's that we need to include all women, especially pregnant women, in research so that we can give them the best possible and most evidence-based prevention options and treatment options for all medical conditions, including HIV. Next slide, please. So moving on to PrEP drugs, we will be going over what's currently available and what's in the pipeline. I want to quickly review some of the new CDC changes. There used to be a long list, laundry list of exposures of HIV risk factors that the CDC listed as eligibility criteria, such as having a partner that was living with HIV, a recent bacterial sexually transmitted infection, such as chlamydia or gonorrhea, and IV drug use. And these still exist, but the new PrEP recommendations, the new PrEP guidelines recommend that medical providers speak with all sexually active adults and adolescents on PrEP, not just people at high risk, in order to increase awareness of PrEP and decrease the stigma about PrEP. So the fact of the matter is that places in DC with really high rates of HIV, like I just showed, sexually active adults are at increased risk of HIV exposure because of this high prevalence of HIV, not because sexual practices are different in DC than they are in, say, Idaho or Montana. And it's important to think about it in that context. Further, the CDC is placing less emphasis on these eligibility criteria and acknowledging that not all patients are going to disclose their possible HIV exposures to a doctor or a nurse, especially if they've just met. And therefore, there's a new recommendation that if a patient asks for PrEP, given how low risk the medication is, that he or she be given PrEP, prescribed PrEP, regardless of whether or not there are documented risk factors. And that's a new and I think really important change and paradigm shift for how we look at prevention and how we end the HIV epidemic effectively. Next slide. So I talked a little bit about FTDF before. It is a daily oral medication. As I also mentioned, near perfect adherence is required in non-pregnant women to achieve the same greater than 90% efficacy that has been demonstrated in men who have sex with men. And again, this is secondary to a 10-fold concentration difference in the cervical vaginal tissue compared to the colorectal tissue. Taken daily, though, it is highly effective and decreases HIV transmission by 92% in heterosexual couples. And this was really the first effective drug that we have had to prevent HIV, which has been really groundbreaking. It is a very safe medication, and we know a lot about it. Some patients do complain of a startup syndrome, which includes some gassiness, some nausea, mild headache, but most symptoms do resolve within the first 30 days. And there's a documented, I can't talk right now, sweetie, I'm sorry. There's a documented bone mineral density decrease that is associated with FTDF. Excuse me. Sorry about that. That is associated with a 1 to 2% decrease in bone mineral density. So like osteoporosis, but this has been less of an issue in our HIV negative population. And we know that it decreases returns back to baseline after discontinuation. And there's been no long-term impact in, for example, adolescents whose bones are still developing. Lastly, there's a theoretical concern for decreased kidney function, but that really, again, hasn't been very significant at all. Next slide. The next medication I want to talk about, the next PrEP drug I want to talk about is tenofovir alafenamide, or TAF, which again is a daily oral medication which is FDA approved for pre-exposure prophylaxis, but only in men who have sex with men and transgender women who have receptive anal intercourse. It is approved in all men and women for treatment of HIV, just not for prevention. It's similar to FTDF in that both are prodrugs of tenofovir, meaning that they're activated into their active form after you ingest them. But one of the main differences is this has less effect on both bone and kidney, which is great. It has been studied extensively as part of HIV therapy and treatment for men and women, but just not, there's still limited data on safety and efficacy as pre-exposure prophylaxis in cisgender women. But there are studies that are ongoing, and we're hopeful in the next couple of years that it'll be approved for women, for cisgender women as well. Next slide. The next drug I want to talk about is the dapivirine ring, which is a little bit complicated to discuss, but we're going to get into it. It's an intravaginal ring that patients insert monthly. It has minimal systemic absorption, meaning that it really just absorbs in the tissue in the vagina, and it offers local protection as a result, similar to a microbicide, if anyone's familiar. And it offers women who struggle with taking a pill every day or with swallowing pills, it offers them an alternative. It's worth noting here that in the original pill PrEP trials, the oral PrEP trials of FTDF, in women, they actually weren't found to be effective. And the reason why is because women didn't like taking a pill every day for something that was prevention. You can often convince people to take a pill for a known health problem like diabetes, or when people know that they, have high blood pressure, but to prevent something, it's often hard to convince people to take a medication every day. And so this ring offers a monthly alternative to taking a pill every day, and offers the potential for protection against HIV compared to doing nothing at all, given the differences in adherence. So there were two trials. One was the Aspire trial and one was the Ring trial, and both were compared to placebo, meaning a ring that had nothing in it effectively. And the dapivirine ring was found to reduce HIV by between 27 to 37%, depending on the trial, and depending on the subgroup analysis, which is it's not fantastic, but it's a lot better than nothing. And it's really important to recognize that it is an alternative for women that really just can't take an oral regimen on a daily basis, and it is very safe. And it's just really important that we find more accessible and acceptable options to women for HIV prevention as part of ending the HIV epidemic. Next slide. The long-acting cabotegravir injection is likely the next drug to be approved by the FDA for PrEP, hopefully for both men and women. It is a every 2-month injection. It is amazingly effective compared to oral PrEP, not compared to placebo. And a lot of this, again, probably has to do with adherence, in that if you get your injection, you don't have to remember to take a pill every day. The injection is every 2 months. There are some concerns largely around implementation of all the visits for injections, and also how to safely transition individuals who are on CAB off of CAB once they decide that they no longer want to receive injections. It is currently FDA approved only for treatment, but it's anticipated to be approved for PrEP as soon as February. Next slide. Islatravir is currently in studies. We actually have 2 trials going on at MHRI. There is a monthly pill and a yearly implant, which are currently in phase 3 and 2 respectively. Next slide. So we currently have, I want to say, about 6 PrEP studies currently open. I'm going to mention 3 of them, but if anyone is interested in participating in PrEP research, please reach out, and the contact information for my research team is on one of the subsequent slides. If you don't see a study here, or I don't mention a study here that fits your demographic, we may have other opportunities, or we're happy to take your information for future trials that we may be opening. Next slide. So we have 2 studies on islatravir. One is a study specifically in women of a monthly pill. It's a randomized controlled trial of FTDF compared to a monthly islatravir pill. And there's a second slide that will be for an implant in both men and women in healthy controls. Both of these studies are currently on temporary hold to evaluate a potential safety signal, but we anticipate that both will be open to enrollment again in the next couple of months. Next slide. You can actually skip this one. Next slide. And this next study is not a drug study. It is about PrEP, but the objective is actually to talk to women and better understand what they want from PrEP and in what form. How often do they want to be taking it? Do they want a pill, an implant, a shot, and what they want PrEP treatment and care to look like. Next slide. So Trisha Moriarty and Trinessa Hansen are my amazing research team. Trisha is out in the next week and a half, but she will be checking email once she gets back, and Trinessa is on email constantly, and you are more than welcome to email one or both of them, or give their office a call and leave a message. Those are their work cell phone numbers, which you're welcome to use as well. And we welcome your potential future participation in the current trials we have going on or in other future trials. Next slide. So that's it. Thank you so much for your time and attention, and I welcome any questions you might have.